Tell me a little bit about how you got into gynecologic surgery.
Actually, it was during my medical school that we had a gynecologist that was a friend of the family. And he said, hey, anytime that you're afraid you want to come with me, you can be with me in surgery. And I ended up assisting him in surgery as a medical student. So it was easy for me just to jump directly into gynecology because I knew already a lot. That was the reason, actually. And he was a good role model too.
It doesn't always have to be more complicated than that, right?
No, exactly. You like a person, you think they're doing a good job, and then you just go ahead and do it. Yeah.
Who else has mentored and sponsored you in the past and even currently and over the years?
Many, many, many people. I can name colleagues, fellows, residents, students here, international. They have stimulated my thinking with questions and comments. And then it gives you ideas, right? So everybody has mentored me to some degree, but especially there was a general surgeon who specialized only in gynecologic surgery at Mayo Clinic, Rochester, Minnesota, during my residency, Richard Simmons. He was cool, never panicked, and there were no limits for him in the pelvis or the abdomen. And I said, I want to be like this guy.
Well, speaking of, role modeling, what makes a great gynecologic surgeon? To you, what does make a good GYN surgeon?
Well, I've come with the 3 E's. One is the economy of movements. Every movement you do in surgery has to have a purpose. When you see somebody that's trying brushing, they don't know what to do. They're thinking. If you want to do something, you do it once and go to the next one. For me, that's economy of movement. Second, it's efficiency. If you have economy of movements, efficiency, what does it mean? That you finish one step in the surgery and you go to the next one. You finish the bladder dissection and then you go for the uterine arteries. You don't do the bladder dissection, one uterine artery, go back to bladder dissection. That's inefficiency. And the third one is elegancy. You want to look like you are gentle with the tissues, like you treat the patient well instead of fighting, roughing the tissues. That increases more bleeding and it slows you down. So it's the 3 E's: economy of movements, efficiency, and the elegancy.
I love this. I feel validated now for whenever I tell fellows and residents. I always say, at least your first 2, I say be intentional and be efficient.
Yes.
And then I always say slow is fast. So be intentional with your movements.
Yeah, because when you go fast, it bleeds.
Yep.
And then you have to slow down to stop it.
Right. Exactly.
Yeah.
I'm now validated by one of the greats. So that's good. So I love the theme of our upcoming meeting in March. It's surgeons as change agents. Yeah. And so I'm wondering what that means to you. What changes have you seen and what do you see for the future?
So number one, a great benefit has been the number of surgeries is going down. Why? Because we have other innovative therapies that they have, like the Magrina IUD, they have the endometrial ablation, and they have the GnRH analogs. The IBF has replaced tubal surgery. So surgery is going down, which is good, because in surgery, 1, patient may get worse. 2, you may not fix the problem. And 3, you don't know the outcome and you can't guarantee it. So the same as the medication, but surgery is a little more involved. Then I think that the number 2, there are less invasive surgical approaches. For instance, vaginal surgery, yes, but then became laparoscopy, phenomenal. Then laparoscopy that was beneficial for the patients became robotics that was beneficial for the patients and the surgeons. Now we have V-nodes, which also is an improved minimal vaginal surgery, single port in robotics with only one instrument that goes through the belly button. And then also I can think about the radio frequency of fibroids. I've never done it, but I think that if you can put a needle through the cervix or through the vagina into the fibroids, and you just destroy them without surgery, I would call this the super minimally invasive surgery or the extra minimal invasive surgery. So that's the second one. The third one that I can think of is in GYN cancer. We are much less radical in surgery because we have adjuvant therapy that they didn't have in 1951. For instance, the radical vulvectomies now, there are 3 incisions. So the growing problems we had with healing is gone. We have also neoadjuvant chemotherapy for ovarian cancer, which reduces the amount of disease, reduces the extent of the surgery, the mortality. Endometrial cancers, cervical cancers, we do sentinel nodes. We don't do lymphadenectomies anymore. Cervical cancer, young women, we do a fertility-sparing surgery, radical trachelectomies. So we are much less invasive. And I think I've gone through all of this in my career.
So I must ask you, I didn't prep this in the questions, but in terms of what's coming for the future, when it comes to medical education, do you think we're ever going to get to a point where we separate obstetrics and gynecology?
Yes. When I was president of AGL, on my presidential talk, I said, isn't it the time to separate the O from the G? I think it could be a 1 year where you have maybe a view of the OB and a view of GYN in general, because we know the pelvis better than anybody else. We're going to be working in the pelvis all the time. So I think that at that time, it would be like, yes. So where do you want to go? I want to go to GYN oncology. Okay, we'll put you only on GYN and GYN oncology. Other surgical specialties, Cecile, have already done that. The orthopedics don't have to do thoracic surgery or don't have to do abdominal surgery. Plastics don't do it either. Why? Because they're never there. What is the benefit of an ENT learning pelvic surgery? So, and I think that in our field, that change is mandatory. There is no other specialty that I know that combines both together. There is combined. And also, even in GYN oncology, I see that there are those GYN oncologists that they do primarily surgery, like me, are the ones that they do surgery and chemotherapy. Radiation therapy, we don't even get into that because it's more complicated. But we're already divided. And by the way, there is no other oncological specialty that the surgeons do their own chemotherapy except in GYN. Ridiculous. Anyway, yep. It's time to move forward and say, hey, let's revise how we educate GYN oncologists.
Yeah, I think that especially when it comes to surgical volume, this is like at the number one item on most agenda items, whether it be for ACGME, whether it be for ABOG, is this volume issue and getting generalists to be trained enough or subspecialists to be doing the things that they are most likely to contribute to them being really good specialists or subspecialists. And yet the separation always sort of falls to the bottom of the discussion as an option.
Yes.
It's sort of, they seem to sort of be circling around the same concepts on solutions, but yet it always gets brought up, but I don't think everybody's ready to quite move there yet. Subspecialists support this, but it's hard to get those who are very focused on generalist practice to agree to it. So
exactly. The generalists don't want to give this up.
Yep.
Okay, maybe there should be an OBGYN practice.
Yep.
And you basically triage the patients to the field of maternal medicines, infertilities, GYN oncologists, and the other one. So you're basically the doorman or the doorwoman. I said, you go here, you go there. Yeah.
Yep. So shifting gears a little bit and speaking specifically about SGS, what has SGS meant to you, and how has it played into your career?
Oh man, SGS had all my role models. Resident and fellow were SGS members. Even the fathers of the GYN oncology were SGS members because all they did is they talk about the surgery. So it was an inspiration to see these people and hear what they had to say.
Why do you think we're not seeing as many GYN oncologists at SGS now?
Oh, because I think has taken more towards urogynecology.
Yeah.
Because it primarily was a very strong in vaginal surgery, but also in pelvic surgery. And then in time, it has become more urogynecology. So we say, as a GYN oncologist, what can we bring into there? If the most people are not oncologists, and we have already International Society of Cancer, we have the GYN European Society, we have the American GYN Oncology Society. I mean, we have so many already that even Cecile, there was a group of people before the subspecialties were divided called the Pelvic Surgery Society, Society of Pelvic Surgeons, SPS, instead of SGS. And there were colorectals, urologists, and gynecologists interested in oncology, because all we did is talk about ureters, bladders, and rectums that everything that's in the pelvis. We're only pelvic surgeons.
Yep. Oh, that's fascinating. I mean, academic institutions have sort of these multidisciplinary teams, but to be able to get together on a national, and international platform to really exchange ideas is actually a really brilliant idea.
And now SPS is primarily gynecologist.
Interesting. It's sort of the tide has changed a little bit. But you're right about it, SGS being predominantly urogynecology. When we were putting our list together of people to reach out to, we were looking at it and we said, these are all urogynecologists. So we have to make sure that we're at least representative of our membership, and we were, but we did our best to really be inclusive of some other great contributors to the society.
Exactly.
Other than what you just said, anything else that keeps you coming back each year to the meetings?
I mean, it's a wonderful, friendly group. It's a cohesive group. There is not back throats. They present new techniques. You discuss it among friends instead of throwing bullets, you're throwing flowers. That's probably the best way that I can put it.
That's a great way. I hope we end up clipping that. Any memories that you are fond of or can actually share? A lot of the memories happen, like the good ones happen after hours. Anything that you want to share?
Well, my favorite moment was I received the Distinguished Surgeon Award by the SGS. I mean, that was a special moment. It touched my heart. But there was another one, and I think it was in San Antonio, in one of the resorts up in the mountains. And you showed, some people show what they can do. And there is this gynecologist, this young woman gynecologist that goes on a stage and she sings The Little Mermaid. And she is spectacular. I'm going like, this is better than the real thing. So when I finished, I went to her and I said, I gave her a hug. I said, this is phenomenal. I said, why didn't you in medicine instead of being singing with this? She said, Disney auditioned her and gave her the job. And she turned it down.
She, I don't know if it'll make this into the clip, but I'm going to show it to her because she was one of my fellows. So,
oh my God. She was incredible.
Yeah, I know exactly who you're talking about. So
were you there too?
Yes, I was. So I will make sure that I relay that to her so that she knows.
I still remember it. One of my best moments.
Yeah.
It's after hours.
I didn't also send this to you, and some people hate this question, but I think if you hate it, then that actually shows a lot of humility. So my question to you is, eventually, how do you hope to be remembered?
As a surgeon who basically moved past forward what he was able to learn from big people and from everybody. I don't want to keep anything in myself. I want to pass it forward. And I think that all of us who have been lucky enough to receive good training and we've been surrounded by good people, I think we have the obligation to pass it to the young people that comes after us, so that it never gets lost.
Yeah, I think that many people say it. I think that fewer practice that. And so I think that when it is time to remember you, I will validate you back and tell you that I think that's what a lot of people will say about you. So
Thank you.
How you would like to be remembered, I feel almost certain that you will. That is exactly because you have had this influence on a lot of gynecologic surgeons. And so I'm glad that that's actually your wish. So perfect. Not that you're going anywhere anytime soon.
And I'm thinking that now my biggest role now is to even do it more, because I have more time to do it.
Yeah. Mark Walters is is a family member, and we're so close, and he mentored me, and then we were partners, and I saw him out in his retirement. But that's how he spent his last 10 years, was just giving. He didn't have any leadership roles. His leadership was in the OR and with trainees, and that's how he spent. I mean, he did that his whole career, but he really focused on just giving and paying it forward his last 10 years. And I feel really lucky that that's how I got to spend my first 10 years in the field, so.
Yeah, that was a good role model for me too.
Yeah.
Great guy.
Last question. Tell me your favorite GYN instrument, surgical instrument. It doesn't have to be GYN, any surgical instrument, and why?
Well, the first one that comes to mind is the Da Vinci robotic system. Why? Because I've been, I received my certificate in 2004. My driver's license for the console was 2004. And so I've done it consistently since then. So why is my favorite one? Well, like I said before, laparoscopy was great for the patients, but robotics is great for the patients, but the surgeon. It's easier to learn. You're sitting in a console. You have no tremor, so you have more precision. You have 3D vision, superb instrument articulation. And I'm thinking about, what else do I want? Well, I want an instrument that is not that big, that anybody can have it in the urine wars in any country. So lower the price, lower the bulkiness, and then we're all gonna have it. So anyway, yeah, that's my play toy for the OR.
It's a big toy, but I think that it certainly has changed the ability for many people to do gynecologic surgery, but it has also allowed for a lot of innovation.
Sure.
And so you're the first one to bring it up. So I'm glad that you did. That way we'll have some diversity within the group. Like I said, a lot of it has been urogynecology. So everybody likes the GYN vaginal instruments.
Well, in urogynecology, primarily are all vaginal surgeons.
Yeah. The ones the ones I'm talking to, right? Because I'm looking at those who have been contributing for a while to SGS. So for sure, I'm talking to a lot of vaginal surgeons. I'm speaking with Ted Lee next. So,
are you?
Yeah. Okay. So I'm sure he will not give me a vaginal instrument as his favorite. So